Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for June 19th, 2019. Thank you for joining us this month. Our presenter today is Commander Kamil E. Barbour, who is a Supervisory Epidemiologist with the CDC's Division of Population Health. Dr. Barbour's research interests include general arthritis, osteoarthritis, lupus, osteoporosis, and fractures. He is also deployed for numerous public health emergencies, including cholera, polio, Ebola, and Zika. Dr. Barbour received a PhD in epidemiology and a Master of Science in Biostatistics from the University of Pittsburgh and a Master of Public Health from Brown University. He trained in epidemiology with the Centers for Disease Control and Prevention as an Epidemic Intelligence Services Officer. He has authored over 60 journal articles and received numerous public health service awards. He is an active member of the American College of Rheumatology. The title of his presentation today is Knee Osteoarthritis and the Risk of Medically Treated Injurious Falls Among Older Adults, Results from the Health ABC Study. Dr. Barbour?
Thank you for that introduction. It's a pleasure to be here presenting on the OA Action Alliance call today. So, as she stated, this talk will focus on a longitudinal study that we conducted. It was collaboration between the CDC and primarily the University of Pittsburgh. And so, this work has been published online with Arthritis Care and Research almost last year, August 2018, and it's scheduled for print publication in July. So a little bit about the epi of knee osteoarthritis. We know that the prevalence of knee OA is, particularly the radiographic form among older adults, is very high. Over 1 in 3 adults, older adults, have knee radiographic osteoarthritis in the US, and the symptomatic form, which includes pain and radiographic evidence, is at about 12%. We also know from a paper that was done by our CDC colleague, Louise Murphy, who I believe either presented or is presenting for OA Action Alliance, that the lifetime risk of knee symptomatic radiographic osteoarthritis, if you live till the age of 85, is about 45%. In addition to that, we know that knee OA is associated with several poor outcomes, such as reduced quality of life, early retirement, and we know that over 600,000 knee replacements are attributable to OA in the US every year. And there's also been recent evidence that knee OA is associated with an increased risk of mortality. Now, the outcome of falls we also know is very important. Particularly among older adults, it's the leading cause of injury-related morbidity and mortality. And we know that for older adults, 1 in 3 will have a fall. And it has great public health implications also in terms of costs, leading to direct medical costs of $30 billion. So knee OA and falls, what's going on there? What do we know about that relationship? We do know that knee OA leads to poor neuromuscular function, and we know that poor neuromuscular function is a risk factor for falling. And so some investigators have looked at the association between knee OA and incident falls. This was usually using a self-reported falls variable. And though not definitive, there has been some documentation that those with knee OA are at a higher risk of falls among those with knee OA. But we really haven't seen studies that have looked at knee OA and the risk of injurious falls. The injurious falls outcome is obviously the outcome of more public health relevance because we know that the fall led to an injury as opposed to just a generic fall, which could have really not led to anything. So the study objectives of our study was to determine whether knee OA is associated with an increased risk of injurious falls and the overall population, but we're also interested in a priori analysis stratified by sex. So why examine these associations in men and women? Well, for various reasons. One, we know that there are sex differences in pain thresholds. We know there are sex differences when it comes to reporting of pain, and we know that pain impacts behavior differently by sex. So these are some of the reasons to examine these associations by sex. And we were also interested in injury severity. So we looked at those who had an injurious fall that led to a fracture versus non-fracture injurious falls separately as well. So some of you may be familiar with this study population, but for those who aren't, the Health, Aging, and Body Composition Study, it's a study of 3,075 white and black adults, older adults, aged 70 to 79 at baseline. This cohort was taken from Pittsburgh and from Memphis. And for our particular study, it starts at visits 2 and 3. This is when knee radiographs were collected. And participants were followed for over 6 years. This is our study population flowchart. We did not use the entire visit 2 sample from Health ABC. In fact, only 1123 were selected for the study. But after that, we had to exclude a bunch of individuals, and some of our exclusion criteria included those who are missing radiographs, so we can't assess their NEOA status, those who were missing the clinical visit at year 4, so we can't really assess their injurious fall status, and then for certain individuals, we had issues with no fee-for-service in their CMS, and then others that had fee-for-service, but it ended prior to the study baseline. And so that left us with an analytic sample of 734. We assessed NEOA using the traditional Kellgren-Lawrence radiographic criteria. So those with a score of 2 or greater were considered to have evidence of radiographic knee osteoarthritis. And so for this particular study, we wanted to look at several different NEOA outcomes. And so as mentioned earlier, we used a Kellgren-Lawrence scale of 2 or more for radiographic knee osteoarthritis. And then for symptoms, knee pain was defined as having symptoms during the last 30 days in at least 1 knee. And so we categorized all of our participants to 4 mutually exclusive groups. Those with knee symptomatic radiographic osteoarthritis, that was radiographic osteoarthritis and pain. Those with knee pain but without radiographic osteoarthritis, those with knee radiographic osteoarthritis without pain, and then our reference group was those with neither radiographic osteoarthritis or pain. And so our outcome was injurious falls, and we ascertained this using the Medicare claims data that I spoke about earlier. And we were interested in defining injurious falls using the ICD-9 fall codes. And so there were several ways we went about classifying those with an injurious fall. So any event with a fall code plus a non-fracture injury was considered an injurious fall. Any vertebral fracture code with a fall code was also considered an injurious fall. And any non-vertebral fracture code with or without a fall code was considered a fall injury. So those are the decisions we made when it came to classifying injurious falls. And then those with a traumatic injury, intentional injury, or pathologic injury were not considered part of that injurious falls outcome. And so for our statistical analysis, we used pretty classical epi methods when looking at descriptive statistics. So first we were interested in looking at the characteristics by incident fall injury status and NEOA status. So we used chi-square, t-test, and ANOVA. And then for continuous variables with non-normal distributions, we used Wilcoxon ring sum t-test as a substitute for the t-test. And then we used Kruskal-Wallis test as a substitute for the ANOVA test. And for our survival analysis, we used Cox regression modeling to estimate hazard ratios and 95% confidence intervals while checking the proportional hazard assumption and realizing that it was not violated. And so for our multivariate models, we looked at all covariates associated with the exposure or outcome at p less than 0.1 and included those variables in the multivariate adjusted model. So table 1 looks at characteristics by knee OA status and incident injurious falls. And so, actually it's just, characteristics by incident injurious falls. And we find that for injurious, so those who were older were more likely to have an injurious fall, women were more likely to have an injurious fall, whites, those with higher education, and those with a lower BMI. And then this slide looks at characteristics of older adults by knee OA status. And we found that knee OA status differed by age, by race, by site, by BMI level. It didn't differ by physical activity, but it appeared that those with the more severe knee OA had lower levels of physical activity, and also by hypertension status. And so this is our multivariate, these are our regression models that looked at the adjusted risk of injurious falls associated with knee pain without ROA, knee ROA with pain, and knee symptomatic radiographic ROA. And so the first thing to note here is that our reference group is participants without ROA or pain in a knee. So when we looked at the overall population and we looked at our different knee OA groups, we did not find any association with risk of injurious falls in the age-adjusted or in the full multivariate model. And the next table is our table that stratifies by sex. And so we look at these associations individually in men and in women. And so the one striking finding is among men with knee symptomatic radiographic osteoarthritis, the hazard of injurious falls was about 2.6-fold higher than among men without pain or radiographic evidence of osteoarthritis in the multivariate model. And among women, we find no associations whatsoever. And finally, the last table looks at the adjusted risk of fracture and non-fracture injurious falls by knee OA status. And in this particular analysis, we did not find any associations when we just looked at the outcome being fracture versus non-fracture injurious fall. So in summary, in a cohort of older men and women, knee symptomatic radiographic osteoarthritis was associated with a 2.6-fold increased risk of incident injurious falls in men only. When looking at this in the overall population, we did not find any association. We did not find an association among women, and we did not find an association by fall type, fracture versus non-fracture. So why was this association limited to only men? And we can only hypothesize. We do not have the data to be able to make conclusions about this, but some of the hypotheses when reading literature that came to mind I've listed here. The first one is that we know that men and women are more likely to fall. Men are more likely to fall than women under similar conditions of health. Example, osteoarthritis and balance. So what do we mean by that is that women who report pain are more likely to limit their activity than men. And we know that men with similar conditions of health are more likely to put themselves in a hazardous situation than women. So that's just one hypothesis. The second one, literature shows us, is that the women have a lower pain threshold than men. And then finally, men are more likely, we know that men are more likely to only report the severe pain. So it could be that there is less reporting of pain in men and more reporting of pain in women, and that may be kind of impacting our results. So strengths of our study. This is the first study to examine, that we know of today, to examine knee OA and risk of incident fall injuries. And we did not use self-reported falls or self-reported fall injuries. These were all validated diagnoses via Medicare. We have a pretty long follow-up time of 6 years, and we controlled for many, many potential confounders, as you saw in those tables. We did have some limitations. We did have self-report for certain potential confounders that may bias our findings, like physical activity was self-reported. One of our knee-OA groups had a very low prevalence. Those were adults with knee ROA and with no pain in the sample, and thus we couldn't really make any inferences from that particular group. And another minor limitation was that we only had one measurement of knee OA at baseline. So we know that knee OA status can change over time, and so to only assume that knowing the baseline status is not enough information, but that is what we had to work with. And so in addition, we adjusted for many potential confounders, but we know this is an observational study, and residual confounding is a limitation of all observational studies. So what are the public health implications for this study? One thing that we could do to improve this particular situation is to increase dissemination of non-pharmacologic interventions that have been shown to reduce fall risk in older men with knee OA by improving their physical function. And we know that enhanced fitness is an evidence-based physical activity program that we at the CDC recommend and is widely disseminated by the YMCA. And there have been scientific studies that have shown that this particular evidence-based program does improve function in older adults. In addition to improving function, it's also been shown to reduce by at least 26% the risk of falls requiring medical care. So this is an important intervention that we can use for older men with osteoarthritis. So finally, in conclusion, the symptomatic radiographic osteoarthritis was associated with a 2.6-fold increased risk of incident injurious falls in men only. And we know that evidence-based physical activity interventions can improve function, and they may reduce the risk of injurious falls in this population. And given that this is a unique study, probably the first of its kind, we need more studies to confirm this initial finding and explore why this association was limited to men. I'd like to acknowledge my many investigators from the University of Pittsburgh. The Medicare falls data comes from a grant from Dr. Elsa Stratmeyer. She was a senior investigator on the study, and also my collaborators from UCSF and University of Washington. And I'm ready to take questions.
Great, thank you, Dr. Barbour. We do have some time for questions, and a reminder to everyone, you can type any questions you have for Dr. Barbour into the chat box. Also, just want to let you know that in a few minutes, you'll see a poll pop up on your screen with some survey questions about the webinar today. If you have time, please answer those before you leave the webinar. All right, Dr. Barbour, we do have one question here from Amanda Nelson, and she asked, did you look at multiple joint OA, such as having bilateral knee symptomatic ROA, or also having hip OA or other joint involvement?
Hi, Amanda. That's a great question, and that's something we wanted to actually look at. Unfortunately, we did not have the statistical power to look at bilateral OA. We were just powered enough to look at just unilateral OA. So that would have been something we would have loved to have looked at if we had the statistical power.
And Dr. Barbour, you mentioned that there were some participants who had to be excluded from the knee OA substudy. Could you say a little bit about how that analytic sample might have been different, if at all, and would the results be impacted by the differences?
Sorry, I think I was on mute.
We didn't hear you.
So we were definitely concerned initially about those participants who were excluded from the analytic sample and how that may impact the internal validity of the findings, but when we ran some descriptive statistics looking at some of the characteristics of those who were excluded versus included, we found that they were pretty similar populations.
All right, and did you look at reported pain levels, and did pain intensity, if you did look at pain levels, did pain intensity correlate to falls?
Well, I mean, I think we just had that, we didn't have that particular question of pain intensity in our sample. So we looked at just self-reported pain in the last 30 days.
And you mentioned that this is a unique study, but can you speak to how these findings might compare to other similars looking at falls among people with OA?
Right. So, I mean, as I said, earlier in the study, I mean, there is evidence of an increased risk of falls among adults with knee OA, and this is looking at the self-reported falls outcome. So there is some evidence, but there also are some studies that show that there's no association. So I mean, there are kind of mixed findings when it comes to looking at baseline knee osteoarthritis and incident self-reported falls. It's a little bit of a mixed bag, I would say.
And I had a question about the kind of what can people do, and you mentioned enhanced fitness and some other programs, but what if people are not able to get outside their house? What can people do to help prevent their falls?
Well, I mean, you're saying outside of improving their neuromuscular function?
Or just on their own, if they don't have the resources in their community to get into a community-based program, what can they do on their own to reduce their risk of falls?
I think they need to be more physically active on their own, and we know that physical activity is associated with greater function, and so having that greater physical function will likely reduce their risk of fall. So so they could go for walks or just be active, and that would be outside of joining some recreational center.
Mm-hmm. So just moving more.
Moving around, yes.
Yeah. All right. Do we have any other questions for Dr. Barbour today? Well, thank you so much to Dr. Barbour for your presentation today, and to everyone who was able to join us. The poll is on your screen, so if you have a chance, take a look at that before you leave. And we hope that you will join in next month on July the 17th for the Lunch and Learn, where our presenter will be Tina Thornhill, Associate Professor of Pharmacy Practice at Campbell University, and she'll be presenting a presentation called Utilizing the Most Accessible Healthcare Professional in the Management of Osteoarthritis. So thank you, everyone.